so glad that you have decided to come back and join us once again to talk about diabetes and blood glucose regulation. We are going to start off today by talking about hyperglycemia. So let's just get right into it. Hyperglycemia is high blood sugar. This condition is fairly common in people with diabetes. It occurs when the body does not have enough insulin or cannot use the insulin that it does have. Remember, we talked about the cells being a little bit resistant to the insulin and the insulin no longer working as well. So, hyperglycemia can occur during periods of stress. We know that when the diabetic becomes stressed and steroids get released, like cortisol, into the blood, this increases our blood sugar. When they are ill, the blood sugar can go up. In the cases of stress and infection, and even exogenous steroid use. All these things can trigger high blood sugar. And so, there's that word again, exogenous. What do we mean by that? Exogenous is, what was that? You remember? It is any time we have a medicine that we are giving to a person or that a person is taking. So our bodies make steroids, okay? That's endogenous. Endogenous, our bodies make steroids. However, we can also take steroids exogenously, right? We know that some athletes do that. However, we also give it to our patients who have different reasons that they need decreased inflammation in their body. So we might give it to someone who's having, poison ivy, allergic reaction to something. We might give it to somebody for other medical reasons. But what we know is exogenous steroids can cause our blood sugar to go up, okay? And, while I'm on the topic, I think it's important to note here that if we are giving someone exogenous steroids, which again can cause hyperglycemia, that we always taper them down. So we never put someone on a dose of steroids and then we always want to let them know that they must taper down to a smaller and smaller dose before stopping. Because what will happen in the body is as we're taking exogenous steroids, then our body will kind of stop making. And then what we worry about is if our body is no longer making steroids because we're taking exogenous sources and then we abruptly stop taking a steroid, we could have kind of a crisis. We need steroids circulating in our body, or we can have a crisis. It's actually can be lethal. So that being said, let's move on. I want to talk about dawn phenomenon in hyperglycemia. The dawn phenomenon is a normal rise in blood sugar as a person's body prepares to wake up. So we all know that when the alarm clock goes off and we want to hit it and make it go away, that we feel a little stress, right? And that's kind of when our blood sugar rises a little bit normally because our body is saying, well, it's time to wake up. It's time to start your day. And in the dawn phenomenon, early morning hours, hormones like cortisol cause our liver to release large amounts of sugar into the bloodstream. And for most people, the body produces insulin to control this rise in blood sugar, okay? However, if the body doesn't produce enough insulin, the blood sugar levels can continue to rise. And this may cause high blood sugar in the morning before eating, okay? And so how is it possible for you to go into a patient's room and check a fasting blood glucose, right? They've been fasting, they haven't had anything to eat, they just woke up, yet they are hyperglycemic. It is because of dawn phenomenon, okay? So there is another type of effect, Somoji effect, not to be confused with emoji, and I don't even know if I'm saying it perfectly correctly. However, a diabetic who takes insulin in the evening and doesn't eat a regular bedtime snack, okay? What can happen is this person's blood sugar level can drop considerably during the night, okay? If this person's body responds to this low blood sugar by releasing hormones like cortisol, steroids, that raise the blood sugar level, this may also cause a high blood sugar level in the morning, okay? And so you want to know the difference between these two types of hyperglycemia. And I think the really important takeaway from this is that I've mentioned it a couple times now, and that is that in the diabetic, routine is important. So having bedtime snacks at the same time every evening is part of their routine, and it's part of managing their chronic illness, okay? So I want you to keep that in mind. So we are going to talk today about some of the treatments for type 2 diabetes or non-insulin dependent diabetes mellitus. So, treatment for type 2. Wow, look at diet control. It's awfully big there. Exercise, pretty big. Oral hypoglycemics, those are medications that control blood sugar, and insulin, kind of tiny there at the bottom. Why? Because type 2 diabetics, they do make insulin, right? We said that the problem with them oftentimes was that they were kind of resistant, that their cells were kind of resistant to insulin, okay? So we definitely want to work on diet control, and we talked in previous lectures about what a good plate looks like, right? A plate of food that has more lean protein and vegetables that are non-starchy is going to be a better plate for the diabetic. They can have a small amount of some whole grains, but the majority of their plate really should be some lean protein and really mostly half the plate green leafy vegetables or something else, broccoli, something green and something good. Now here's the thing, okay? Diet control is important. Now, we do not want to confuse diet control being important with this ban on sugar, okay? So really new guidelines are kind of lifting the ban on sugar-containing foods to really focus more on attention to controlling carbohydrate intake and individualizing meal plans for the diabetic patient. Because really, what happens is when you get really, disciplined with these folks and try to tell them that they can't have any sugar at all, that becomes very difficult for them to manage, right? I mean, some folks are really good at getting that type of advice and heeding it. Other people just feel deprived, and it just makes them want it even more. Okay? And so what we want to do as nurses is we want to help individuals figure out a plan that kind of works for them. And so there's really growing scientific evidence that sugar affects blood glucose levels no differently than other carbohydrates, and that really no single meal planning method works for everyone. And so what do I mean by that? What I mean by that is the difference between eating, you know, a piece of chocolate cake or eating, you know, a piece of bread, right? We know that a piece of chocolate cake has more refined sugar in it, white sugar. And we know that even though bread is carbohydrate, it's complex carbohydrate. And the thing is that we're finding out that your body is pretty much going to break them both down the same, right? And so what we're saying by this is that our blood glucose isn't going to be much different because what we're finding is that the complex carbohydrates and the really fine, refined and concentrated types of carbohydrates, they're both a problem in the diabetic patient. And what we want to do is kind of get rid of that ban on sugar and just start to approach things in a little more of a moderation type of an approach. Makes people more comfortable, hopefully more compliant. So, what are the benefits of exercise? They're going to be individualized for the patient. However, weight loss is going to help the diabetic. Reduction of triglycerides, which are fats in the blood. Increased muscle tone, improved circulation. Really the best time for them to exercise is following meals when their glucose levels are rising. So having dinner and then going out for a nice walk after is probably a good thing to do. Patients should monitor their blood glucose levels before, during, and after exercise, especially when starting a new routine. So, let's talk about oral hypoglycemics. Oral hypoglycemics are medications that we give to our type 2 diabetics to help control their blood sugar. We have different types we're going to look at in this lecture. We have glucotrol, which is an example of a sulfonylurea. It helps the insulin receptors function better. It increases insulin secretion from the pancreas. So here we see an image to help cement it into your mind. What does glucotrol do? Well, I want you to think about it this way. It helps the pancreas secrete more insulin, okay? That's glucotrol. Metformin, or glucophage, is another type of oral hypoglycemic. It decreases our liver production of glucose and also increases our muscle uptake of glucose, okay? And so when you think about this drug, I want you to think to yourself that it actually decreases liver production. That's what I want you to focus on here. So we see the liver, we see a big cross over it. What we mean by that is that this drug helps decrease the production of glucose by our liver. Therefore, it will help decrease the amount of glucose that is in our blood. There are other types of oral hypoglycemics. This is Precose, which is called an absorption inhibitor. And what this does is it inhibits glucose absorption from our small intestine. And we know from other lectures that our small intestine is where the majority of our food is absorbed. And so if we can inhibit the absorption of sugar in our small intestine, then hopefully we can just get rid of the sugar, right? If we're not absorbing it through our small intestine and it's not going into our bloodstream, then it's going out of our body in our waste. And it will help decrease our blood glucose levels. Okay, so your patient, and most people aren't on 4, however, what I want to give you this example for is so that you understand how to explain to people why they might be on different types of oral hypoglycemics, right? Maybe they are on more than 1. Hopefully they're not on 4. But the patient might say to you, why am I on insulin, glyburide, glucophage, and precose? Okay? So of course, it's important for us to communicate with our patients using understandable language. We want to say insulin is required for glucose or sugar use, right? We could even say that insulin is the key that unlocks the cell so that glucose can be used in our muscles and stored in our liver. We can say that glyburide helps the cells use insulin better, okay? So that's different, right? Insulin helps unlock the door. Glyburide helps the cells use it better. Maybe glucophage prevents your liver from making more glucose, we could say. Or precose will prevent sugar from being absorbed in your food, into your body from your food. So these are just kind of like ways that we can teach our patients using like simple language for how these medications work inside the body. Here's another good one. You're doing clinical prep and you see that your patient who is a diabetic is on lisinopril, which is an ACE inhibitor. And you are just such a good little researcher, and you go into clinical the next day and your clinical instructor says to you, why do you think your patient that is a diabetic is on an ACE inhibitor? And you say, well, I researched it and I found out that lisinopril is a blood pressure medication. So my patient must be hypertensive. They must have high blood pressure. You go back and you look in the chart with your clinical instructor and they don't. They don't have hypertension. So if you would remember this little clinical pearl in this lecture, you might be able to remember that ACE inhibitors help protect the kidneys from damage that can be caused by diabetes. And so oftentimes our type 2 diabetics will be put on an ACE inhibitor even if they are not hypertensive. Why? In order to protect their kidneys. So there you go. You can be really smart when your clinical instructor asks you why. All right. So we said that type 2 diabetics don't really need insulin, right? They make insulin. Their pancreas does make insulin. But we did say that their cells are kind of desensitized to it. So during times of hospitalization, in order to achieve tight blood glucose control, we might have our type 2 patient on insulin. And what are the benefits during hospitalization? Improved wound healing. Maybe they've had a surgical procedure. Their incision site will heal faster if we have tighter control over their blood glucose while they're hospitalized, and less risk of infection, because we know that more circulating blood sugar is a higher medium for infection. So here is the thing. I'm going to take a minute here to just tell you a quick story. I had a patient in the hospital, type 2 diabetic, who did not take insulin at home. And many of them don't. Most of them don't, in fact. And so he's in the hospital. He's post-surgical. And I go into his room after checking his blood glucose with a dose of insulin that was ordered from his sliding scale. Remember, we talked about sliding scale a while back. And he said, "What are you doing?" And I said, "Well, you are getting some insulin today because your blood sugar was 201 and the sliding scale says that you need to get 2 units. And he said, "You're not coming near me with that insulin. I don't take insulin. Go." And I was like, "Oh, I've seen it happen on more than one occasion." Now, how do you think I responded to this individual? I thought to myself, oh yeah, right. He doesn't take insulin at home. He's not used to this, okay? And so it became incumbent upon me at that point to teach the patient why we might use insulin while they're in the hospital for these reasons right here. And once I sat down and explained this to him, very simply, he was actually quite okay with it and said, "Sure, you can give me insulin," because he understood the reason why, the rationale behind it, okay, that it was for his benefit. Does he have the right to refuse the insulin? Absolutely. And I, as a nurse, must respect that decision. However, I think it's important for us to all realize that we must educate the individual first on the costs and the benefits for refusing whatever it is that they are not comfortable with. Okay, so I want you to keep that in mind. So, acute failures in glucose regulation, we've talked about this several times now, can result in neurologic compromise from confusion to coma and brain death. And so on the other hand, high glucose is easier medium for infection, right? So when we talk about glucose regulation, again, we want to remind ourselves that's important for balance, right? Balance. Euglycemia, right, which is considered to be a blood glucose level, which is in the normal range, which generally speaking is somewhere about 70 to about 110 or so. And we're going to talk about that right now because we're going to talk a little bit about diabetes and labs. So when we talk about a fasting blood glucose, what we're saying is that the individual was not eating anything for at least 8 hours, and usually it's overnight, all right? And so there are a couple of ways that we can check a fasting blood glucose. First thing in the morning, hopefully, after they've had nothing to eat or drink, we can do a venous blood draw, and we can check their blood for serum glucose level, or we can do a finger stick or a capillary blood glucose, all right? And this just involves using a lancet to get a very small sample of blood from the finger and check it on a glucose monitor. So that is a fasting blood glucose. A fasting blood glucose of around 110 is considered good, better sweet than sour. What do we mean by that? Really, too low of a blood sugar is the most dangerous. When the brain has no source of glucose, it is much, much more dangerous for the individual than when their blood glucose level is high. And so it's important for us to be concerned about high blood glucose and treat it. However, when we have somebody with a very low blood glucose, we must intervene promptly. Hemoglobin A1C, I mentioned it in a previous lecture. Here I'm actually going to talk about what it is. An A1C actually shows the amount of glucose that has been attached to the hemoglobin molecule over the span of its life. All right, and so here we see a red blood cell, and we see some glucose on that red blood cell. We see somebody getting their blood drawn. They are getting a hemoglobin A1C drawn so that their physician can see how well their blood glucose has been controlled over about the last 120 days. And because the lifespan of a normal red blood cell is about 120 days, the results of this test reveal the overall glucose control for the past 4 months or so. Okay, so if you don't have good control and your hemoglobin A1C is elevated, then the doctor will know that you probably have not been following the recommendations for controlling your blood glucose levels. The goal is to have this lab value about less than 7%. Okay, we've seen this before. We can see here that normal hemoglobin A1C is below 5.7. Pre-diabetes is between 5.7 to 6.4. And diabetes is when we have a hemoglobin A1C of 6.5 or higher. We talked before about dyslipidemia in the diabetic. And so we would like to see triglyceride levels lower than 150 and LDL or bad cholesterol lower than 100. The American Diabetes Association recommends that people with diabetes strive to get their triglyceride levels and their LDL levels in a good range. Okay, and here you can see what those values are. Other labs that we might check is a microalbumin, and microalbumin is a urine test that determines the presence of albumin in the urine. Albumin in the urine is called microalbuminuria. Albumin is not normally present in the urine because it's filtered out from the bloodstream by the kidneys. So if the kidneys are not working as well, as tends to happen in diabetes, then we know that there is an indication that there could be early damage to the kidneys. So we will be checking for this in the urine. Failed glucose regulation can result in vascular disease affecting nearly every organ. Here we see poor wound healing happening in this individual in the lower extremities. This is a wound that is not healing. We've talked about some of the different reasons for this, increased blood sugar levels and problems with circulation as well. And so neuropathy, also known as nerve damage, peripheral neuropathy is a problem in the diabetic patients. And this can result in pain, lack of sensation. You don't feel a small blister on your foot, and then it ends up turning into a very large blister because you never noticed it. So something that we teach diabetics is to do regular inspections of their feet so that if they have nerve damage, they will be able to see that they have a little blister on their foot before it turns into a big blister on their foot that won't heal. And so neuropathy is nerve damage. Neuro meaning nerves, and pathy kind of referring to disease or pathologic process. Not to be confused with nephropathy. Nephropathy is kidney disease, okay? Kidney disease. And diabetic nephropathy happens in diabetics because the circulation to the kidneys is very let's say microscopic, very tiny, and diabetics tend to have problems with circulation to their kidneys, which can lead to kidney disease. There's that microalbuminuria again, which detects kidney damage at an earlier stage. So there will be yearly screening of the urine, and we will be looking for problems with the kidneys. Atherosclerosis, or clogging of the arteries. So failed glucose regulation can lead to atherosclerosis. Here we see a normal artery on one side. On the other side, we see this lipid accumulation. We talked about the dangers of having high blood triglycerides in the diabetic patient. Atherosclerosis is one of those things that can happen. Kidney disease, nephropathy, we said disease of the kidney caused by damage to the small blood vessels or the units in the kidneys that clean the blood, can lead to a patient needing hemodialysis 3 times a week, where they have to go and a machine does the work that the kidneys is supposed to be doing. Failed glucose regulation can result in retinal damage and can cause blindness. Generally speaking, uncontrolled diabetes, high blood sugars that go on for 5 years up to 10 years, eventually can result in blindness. And so it's important to educate people about the risks of not controlling their blood glucose. And I hope that you have gained a better understanding of the different complications that can occur as a result of failure of glucose regulation. I really appreciate your attention to this material, and happy studying until next time. Aloha.